FCCM, welcome. And thank you to the conference organizers for arranging and hosting this great event. My name is Laura Evans. I'm a medical intensivist and a member of the Society of Critical Care Medicine Council. I have the privilege of getting session 2 started. Hopefully, as you can see on the agenda, we have a really terrific session planned. We'll kick it off with the chair of the PADIS guidelines, John Devlin, is here. We'll also have Neal Thomas from Penn State University to update us on ARDS in children, and John Reilly from the University of Pennsylvania to give us an update on balancing sedation and our goals of mechanical ventilation. I'm going to leave it up to our 2 moderators, Drs. Amy Arrington and Shari Brosnahan. We may change the order of the speakers just a little bit in the interest of time. So on that note, it's my pleasure to introduce our 2 moderators who are going to take over from here. They'll be introducing our speakers, and then they'll be facilitating the question and answer period at the end of the session. So our 2 moderators today are Dr. Amy Arrington. Dr. Arrington is the section chief of Global Biologic Preparedness and in a pediatric intensive care unit attending at the Baylor College of Medicine and Texas Children's Hospital. She's also the medical director for Texas Children's 8-bed pediatric special isolation and biocontainment unit in Houston, Texas. And her research interests are in pediatric ICU and pediatric virology and special isolation, including the care of patients with high consequence infections such as Ebola, avian influenza, and MERS. I'd also like to introduce Dr. Shari Brosnahan. Dr. Brosnahan is a clinical instructor at NYU in the Division of Pulmonary and Critical Care Medicine. She's also the Assistant Program Director for the Pulmonary and Critical Care Fellowship Training Program and the Medical Director of Respiratory Therapy at Bellevue Hospital. Shari's research interests include ICU survivorship, chronic thromboembolic pulmonary hypertension, medical education, and optimizing organ procurement for transplantation. So with that, I'm going to turn it over to Amy and Shari to kick us off and introduce our speakers and then moderate the question and answer period. And I just want to thank everybody again for joining us, and thanks to the organizers for putting on this wonderful day. Amy and Shari, it's all yours.
Thank you, Laura. So we're going to change the order just a little bit. I'd like to take a minute and introduce Dr. Neal Thomas. He's Associate Dean of Clinical Research and Professor of Pediatrics and Public Health Sciences at Penn State University College of Medicine in Hershey, Pennsylvania. He's the Vice Chair of the Pediatric Acute Lung Injury and Sepsis Investigators Network and is one of 3 members of the organizing committee of the Pediatric Acute Lung Injury Consensus Conference, which first identified pediatric ARDS. So without further ado, let's start our talks.
All right, thanks very much for the opportunity to speak and describe what we have accomplished over the past few years. I wish I had more time, but hopefully I will interest enough people that we can continue to advance this field. So I'm going to go back a few years and talk about 2015 and understand where we were with our understanding of pediatric ARDS. And the key was that we were still using old definitions, and we didn't have definitions that were specific to children. And quite honestly, we really had very little understanding of the differences between adults and children. So what I like to say is where we were in 2015 was really 1994. The reason I say that is because 1994, as everyone likely knows, the first definitions of ARDS were made by the American European Consensus Conference. And most of what they did was based on the initial report from what people technically call Ashbaugh-Petty, as you can see as 4 authors, that described acute respiratory distress in adults. And when you read this publication from 1967, it's interesting that there were really just 12 patients that had acute respiratory distress with cyanosis and diffuse infiltrates. So it really introduced something that we all see in our ICUs, both adult and pediatric now. But getting back to 1994, the Consensus Conference got together and really tried to formalize definitions to understand this syndrome that we all treat. And their criteria were fairly straightforward, that patients need an acute insult, they required bilateral chest X-ray infiltrates, a PA pressure of less than 18, and they classified either acute lung injury or ARDS based on your P to F ratio. And many felt that there were some shortfalls in this even from the beginning. First of all, in 1994, many of us were still putting in PA lines, but now they really became less utilized, and so many felt estimates were sufficient. One of the things that always bothered us in pediatrics was that it really required an arterial blood gas, and so the subjective determination of the provider at the bedside to obtain an arterial blood gas as opposed to using pulse oximetry really impacted the diagnosis. And the second thing is that it really didn't take into account at all ventilator strategies or the impact on PDAF ratio. And what I show here is the same patient 4 hours apart, really just with an increase in PEEP and increasing the mean airway pressure. You can see that on the X-ray on the left, they have a PDAF ratio of 100, which would be considered severe ARDS. And then a few hours later, just with some ventilator changes, their PDAF ratio was 240. So really, what people are doing with the ventilator really impacted the PDAF ratio. I will say that these definitions were standard. They were used for many years by the NIH ARDSnet, and even for our own studies in pediatrics, we used them for over 20 years. I will note also that there wasn't a pediatrician on the consensus conference. So we had talked about this for a few years prior to the Berlin definitions, but we knew that there was a group meeting and we're going to revise the adult definitions. So we held off for a few years until we saw what the Berlin definitions were going to look like to see if they answered some of the issues that we had. And the Berlin definitions certainly were better. The format stayed the same with the timing and the chest x-ray and the origin of edema. And then they got rid of the acute lung injury criteria and just defined mild, moderate, and severe based on PDAF ratio and with some PEEP or CPAP. And they actually had reasonable data that showed that these were good definitions in terms of outcome. So as you can see, the mortality had a stepwise increase from mild to moderate to severe, and the ventilator-free days had a stepwise decrease with these three classifications. So there was some good face validity to these definitions when they came out in 2012. So what was better? Well, they used some measure of ventilation, which was an overall measure of PEEP. They used one term, which was ARDS, with some qualifiers. And they made cardiac failure more subjective. Again, didn't require a PA line, which is something that was not common in practice anymore. But what was not better? Well, as we just spoke about, they still required an arterial blood gas for this PDAF ratio, and this really limited the impact for patients who did not get blood gases or did not routinely place arterial lines. And then PEEP, while it was an overall measure of ventilatory support, still does not take into account other things that can impact your PDAF ratio. And again, I will state there's no pediatric representation in the Berlin conference. So what about the kids? Where do pediatrics fit in? How can we use these basis of definitions to diagnose what we see in children all the time? And really what I'm going to talk about is the Pediatric Acute Lung Injury Consensus Conference. This was an idea that we had discussed in the PADIS network, the Pediatric Acute Lung Injury and Sepsis Investigators Network, for a few years. And myself and Philippe Javet from Montreal and Doug Wilson at the time was at University of Virginia. The three of us got together and tried to figure out how we can tackle this and how we can develop some definitions and also expand some of the research goals for pediatric ARDS. And so we really had 5 goals. The first was to develop a definition and severity criteria for ARDS in children. We wanted to, as we were all clinical trialists, define appropriate study populations for these children that we see in our ICU. We wanted to look at primary and ancillary therapies for treatment. We wanted to define clinical decision endpoints that included when to put someone on a mechanical ventilator, when to transition them to different modes of ventilation, when to transition to high frequency, which is something we still use frequently in pediatrics. So what I talked about was the slides that you're seeing sort of fly in front of you now, and I'm more than willing to share these with anyone who is interested. We talked about the what was perceived as the shortcomings of the ARDS definitions in adults, both in 1994 as well as 2012 with the definitions from the Berlin group, which showed the increase in mortality and the decrease in ventilator-free days, and some of the issues with what we felt were the shortcomings. And so the PLEAT conference, the Pediatric Acute Lung Injury Conference, was, as you can see, sponsored by these organizations. And it's something that we really tried to move the needle forward in terms of pediatric ARDS. I was describing the aims, which was the definition and severity, to find an appropriate study population, to define primary and ancillary therapies for ARDS, to define clinical decision endpoints. And then finally, as we're all clinical trialists, we wanted endpoints for clinical trials, both short-term and long-term, as survival is now the key in pediatric ICUs, and that most children will survive their pediatric ICU stay. We felt very strongly that we needed to follow survivors post-ICU, which we have not done very well to date in the field. And so this was our timeline. We started in 2012 and we ended in 2014. We actually kept to our timeline, which was pretty remarkable considering the work that was put into it by a number of people. And these are the people that we had. We tried to get representation across the United States and Europe, as well as Australia. And we tried to mix in senior investigators with some junior investigators in the field. And so we tried to mix things as best as possible. We knew there wasn't a whole lot of literature in the field, and that was one of the reasons that we chose our expert recommendations methodology, because we knew there's high variability in practice. And so we really focused on using the RAND UCLA method for determining agreement or disagreement. If you care at all about this, we published a methodology paper while we were in the middle of it in 2013 in Pediatric Critical Care. So we ended up with a total of 151 recommendations. We had agreement on all of them, and some of that was on purpose. So we did change the wording on some things. So we tried to get agreement. And so if we had a not in there, we removed it so we would get agreement instead of disagreement if people disagreed with something. And the main publication was in Pediatric Critical Care a few years ago. You'll notice the author is the entire group, and we did this on purpose. We didn't want one person or a group of people called out. We wanted it as a publication from the group. We also published at the same time a supplement in Pediatric Critical Care, which included all of the subgroups which I showed you that answered the questions that we tried to address related to our aims. And this is something that is a great resource. It's a little bit outdated now, and I wish I had time to show you the new data that we've accomplished since 2015, but in the interest of time, I won't. So the definitions, the first thing we did, which was different from the adult recommendations, was we used oxygenation index, or OI. And we did this because it really takes into account mean airway pressure, and that was something, as I initially spoke about, we wanted some overall measure of mechanical ventilation. And we also, for patients who did not have a PaO2, we used what we call the oxygen saturation index. Now, this is a metric that we developed in 2010 and we validated in 2012, where it really just substitutes the for the PaO2, if one isn't available, with an oxygen saturation or an SpO2, as long as your saturations are less than 98%. And they're the formulas there. I think hopefully everyone knows them, but they're fairly straightforward. And again, to apply the SPO criteria, due to the hemoglobin dissociation curve, you really need to have saturations less than 97%. So this is something that we've tried as a QI project across a lot of our ICUs. What we call 97 is the new 100, really trying to get people to wean oxygen, because we all found that everyone likes to see saturations of 100%, even on high levels of oxygen. So these are our definitions. We took the same format as the Berlin criteria. We included age with all patients outside the perinatal lung disease. The timing and the origin of edema was the same. The thing that was most controversial was the chest X-ray image finding, and after a lot of discussion, we determined that only unilateral infiltrates are required. And that wasn't because we didn't feel that bilateral pulmonary pathophysiology was important. It was because if you review the literature, the reliability of two people reviewing the same X-ray, whether it's two intensivists or intensivist and a radiologist or two radiologists, is very poor. People just do not read the X-rays the same way. And then because we use a lot of non-invasive ventilation, we had a group for non-invasive, and then we defined our mild, moderate, severe based on oxygenation index or OSI, and you could see the numbers there, 4 to 8, 8 to 16, and greater than 16. And this was based on some data that we had. This was this data set. We've subsequently prospectively collected data that shows us that these markers seem to be okay. This is data from Robbie Kamani Children's of LA, where you can see that there does seem to be a stepwise increase between mild, moderate, and severe based on the OI criteria. We also, specific to pediatrics, we have populations that we know they can have pediatric ARDS, but because they're hypoxic at baseline or they have some edema at baseline, they don't get included in a lot of these. So we threw out these definitions for special populations just to draw attention that these patients exist and hopefully lead to future research. Finally, we looked at an at-risk group, or patients who were not quite sick enough to, in terms of hypoxic enough, to have pediatric ARDS, and you could see we defined them there. And this is a patient population that has been understudied, but if we can predict which children will progress to pediatric ARDS before they get severely hypoxic, we may be able to intervene and stop that from moving forward. So what about other management? I'm going to talk real quickly about some of the other things that we had, again, a total of 151 recommendations. We really wanted to make a recommendation as far as mode of ventilation, but the literature just wasn't out there, so our only recommendation was that we really need to study this further. Tidal volume was, again, very controversial. In the adult literature is very consistent with low tidal volume ventilation. The pediatric literature is consistent at best and controversial at worst. As far as low tidal volume ventilation, we determined that 5 to 8 cc's per kilo was a broad range for people with pediatric ARDS. And then if you have severe ARDS or poor compliance, 3 to 6 cc's per kilo. Again, this is very controversial and something that we're looking into right now, hopefully with a prospective trial. As far as transpulmonary pressures, we recommended a plateau pressure of 28 centimeters of water, allowing to 32 for lungs that are a little bit stiff or chest walls that are a little bit stiff. And we really wanted to recommend moderately elevated PEEP. We do have data both before the consensus conference and afterwards that pediatricians generally get to 10 centimeters of water of PEEP, sometimes 12, and then they stop and just turn up the oxygen. It's pretty remarkable. We just published a paper this year that showed that the further that children are treated away from the ARDSNet PEEP FiO2 grid, the worse their outcome. And so it is something that pediatricians need to pay more attention to. SpO2 was also pretty controversial as far as weaning. We recommended a target of 92 to 97. And then if you need to use an SpO2 target of less than 92 to make sure that you monitor for oxygen delivery, whether it's a lactate or a mixed venous saturation or whatever your marker is. We had a section on non-invasive positive pressure ventilation, and really the main recommendation is use it early and not late, because if you use it late, it seems like those children have a higher mortality, and we have some subsequent data to show that. And then we really wanted to make sure that patients were followed up long term. This is something that we don't do very well. We're starting to do now. There's more publications. But we need to know what happens to these children, not only in terms of quality of life, but in their lung function. And I'll stop there in the interest of time. If anybody's interested, I have a whole another set of slides on what we've done since 2015 that I'd be happy to share. Thank you.
Okay, I'll take the honor of introducing Dr. Reilly. He's an assistant professor of medicine at the University of Pennsylvania Lung School of Medicine. He's a medical intensivist who conducts clinical and translational research in ARDS and sepsis.
Great, thank you so much. And thank you so much for giving me this opportunity to present today. I was asked to present on a complicated decision we make in the ICU in patients with ARDS, and that's balancing lung protection with sedation when patients are dysynchronous with the ventilator. Should we sedate the patient more or liberalize the ventilator settings? Now, I'll tell you that we don't have a definitive answer for this question, but I'll review some of the evidence to kind of go through how I take an approach to this question. My only disclosure is that I have research funding from the NIH. Now, we all know that the acute respiratory distress syndrome is a major problem in our ICUs. In the United States, it's 7% of ICU admissions, and there's an estimated 190,000 cases per year. And we still have a mortality that's very high at 30 to 50%. we have no targeted pharmacologic therapies targeting the alveolar capillary dysfunction in ARDS. So mechanical ventilation has really become the cornerstone of treatment for ARDS. And there's been several positive trials in ARDS, and I'd like to review some of the details of the three largest positive trials in ARDS. And the first, most people know of, the ARMA trial published in 2000 by the ARDSnet investigators. This was a trial of 861 ARDS patients. They had a PDAF ratio less than 300, so it included all mild, moderate, and severe ARDS. And they randomized patients to either receive control tidal volume of 12 cc's per kilo of predicted body weight with maintaining the plateau pressure less than 50 centimeters of water, or an intervention of 6 cc's per kilo of predicted body weight with the plateau pressure less than 30. And there was a strict protocolized approach to mechanical ventilation, and they found that they reduced mortality from about 40% to 31%. You can see this in the Kaplan-Meier curve on the left of the screen. They also got people off the ventilator faster and out of the ICU and out of the hospital faster. Landmark trial in ARDS that changed our ventilator management in these patients. Now, the next positive trial in ARDS came in 2010 with the Acute trial that looked at neuromuscular blockade in patients with moderate to severe ARDS. 340 ARDS patients, these patients with a PDAF ratio less than 150 who were early in their onset of ARDS, within 48 hours. Now, in this trial, all patients were heavily sedated. So before being randomized to cisatracurium or placebo, they had to have a Ramsey score of 6. So they were very sedated patients, and they received 48 hours of cisatracurium or placebo. And in this scenario, there was a mortality of 31.6% in the cisatracurium arm versus 40.7% in placebo. While unadjusted, this was not statistically significant at 90 days. When they adjusted for some imbalances in the baseline PDAF ratio and severity of illness, they showed a statistically significant hazard ratio with reduced mortality with cisatracurium. Now, one of the challenges of this trial is both they compared heavy sedation plus neuromuscular blockade to heavy sedation alone, but they didn't have an arm where there was an attempt to minimize sedation. The trial came in 2013, the PROSEVA trial that looked at prone positioning in ARDS. Now, in this trial, there were many trials prior to this trial looking at prone positioning that were negative. But in a meta-analysis, they found that patients that had more severe ARDS and had a more prolonged period of proning had a benefit from prone positioning. So they performed this prospective trial of ARDS patients with a PDAF ratio less than 150 and an onset of ARDS within 36 hours, so early in ARDS. And patients received 16 hours a day of proning in the intervention arm or remained supine in the control arm. They saw a dramatic reduction in mortality of 16% in the proning arm versus 33% in the supine arm of the trial. Now, in this trial, again, most patients were heavily sedated, and in the control arm, about 80% of patients were also paralyzed. And in the intervention arm, about 90% of patients were also paralyzed. So again, we don't have a comparison to an attempt to minimize sedation. Now, what all of these therapies have in common is they're trying to reduce ventilator-induced lung injury, or VILI. Several mechanisms by which it may injure the lung. We have volutrauma from overdistension, atelectatrauma from the repeated recruitment and collapse that we try to overcome with PEEP, biotrauma, where we use where there's a thought that the stretch of the lung releases inflammatory mediators that injure the lung. Barotrauma from the high pressures inducing lung damage, and then the toxic effects of oxygen with elevated FiO2. Now, all of the therapies that have been shown to benefit patients with ARDS are probably affecting that through reducing VILI. We know low tidal volume ventilation and high PEEP may reduce VILI, as well as neuromuscular blockade is thought to promote vent synchrony and reduce VILI. And then in prone positioning, the thought is that in prone positioning, there's a more homogeneous distribution of ventilation, reducing VILI. Now, on the other side of things, there's been a real movement in critical care towards reducing the amount of sedation we give patients. In the past, it was thought that by sedating patients on a mechanical ventilator, we're preventing them from feeling distress while on the ventilator. numerous studies that have shown that by reducing the amount of sedation, we improve outcomes. So the most significant study that looked at ICU sedation was the ABC trial. This was a landmark trial published in 2008 that compared a strategy of daily spontaneous awakening trials paired with spontaneous breathing trials to usual care plus an SVT. And in this trial, not only did they get patients off the ventilator faster, they got them out of the ICU faster, out of the hospital faster, and there was a mortality benefit to awakening patients on a daily basis. Now, that leads us to the question that we have at hand. Should I sedate the patient more or liberalize the ventilator settings? And the answer, in my opinion, is that the evidence is really unclear, but it probably depends on the patient. So let's go through the possible benefits and potential harms of these two different strategies, plus or minus paralytics. The possible benefits include improved ventilator synchrony. We have complete control of the tidal volumes and plateau pressure and can ensure low lung-protected mechanical ventilation. There's reduced oxygen consumption and CO2 production in the paralyzed and sedated patient. And then maybe it's required to sedate a patient to institute prone positioning and ECMO. But there are also potential harms here. The potential harms include ventilator-induced diaphragmatic dysfunction by disuse of the diaphragm. We may have increased delirium, and there may be worse long-term cognitive outcomes from the use of heavy sedation. There's also thought that there's a risk of long-term neuromuscular weakness, particularly when paralytics are paired with corticosteroids. And then there's thought that there's an uneven distribution of the tidal volume when the tidal volume is purely delivered through mechanical ventilation. Now, how about the other approach, using light sedation plus or minus spontaneous breaths? So the possible benefits here are first that when spontaneous breaths are part of a patient's breathing pattern on the ventilator, there's more homogeneous ventilation. There's more ventilation to the dependent part of the lung and recruitment of the dependent parts of the lung. We might have decreased diaphragmatic atrophy, and it's possible this will improve long-term outcomes if it doesn't affect mortality. Decreased interthoracic pressure because of the negative interthoracic pressure from spontaneous breaths, which may improve hemodynamics and cardiac output. Harms, though. The main concern is VILI, that we may result in elevated transpulmonary pressures because of the addition of spontaneous breaths to the mechanical breath, as well as elevated tidal volumes. Prevent asynchrony, and patients may be more uncomfortable. It's also difficult to institute proning and ECMO in a patient that's lightly sedated. So let's talk a little bit more about these spontaneous breaths in ARDS. So spontaneous breaths improve oxygenation, reduce diaphragmatic injury, and may increase alveolar recruitment in the dependent parts of the lung. But there's significant concern that spontaneous breaths may also cause VILI. Now, there are several ways that they may cause VILI, and in experimental animal models, spontaneous breaths are more likely to cause VILI in animals that have pre-existing ARDS and severe ARDS. Injury from spontaneous breaths are first that the distending pressure or the transpulmonary pressure may be greater than your measured plateau pressure and result in larger tidal volumes. And I'll show that in more detail in the next slide. May have increased lung perfusion because of decreased interthoracic pressure, resulting in increased preload, and that increased lung perfusion may increase alveolar capillary leak. And then last, patient ventilator asynchrony, such as double triggering, can result in tidal volumes twice the size of the tidal volume you're planning to deliver. So this is a schematic of the lung to show how pressures can change based on if a patient has spontaneous breaths or not. On the left side of the slide, we have a mechanically ventilated patient that's passive. So we're trying to measure the transpulmonary pressure. And the transpulmonary pressure is equal to the airway pressure, which we measure by the plateau pressure, minus the transpleural pressure. And in a patient that's passive, you may set an airway pressure of positive 30 centimeters of water and have a transpleural pressure of positive 5 centimeters of water, resulting in a transpulmonary pressure of 25 centimeters of water and protecting the lung. Spontaneous breath to this mechanical breath you reduce transpleural pressure. And on the right side of the slide, you can see a transpleural pressure of -20. Wave pressure of 30 centimeters of water results in a transpulmonary pressure of 50 centimeters of water, potentially injuring the lung. So, taking all this information, how do we apply this to our actual patients when faced with the situation and the decision as to whether to more heavily sedate a patient or liberalize their ventilator settings? And I'll just give you one approach that I take in this situation, although I recognize that this is not an easy question to answer. Now, when a patient's intubated for ARDS, my first step is to optimize lung protective mechanical ventilation. So optimize PEEP, reduce the tidal volumes to 60 Cs per kilo if possible. And then after you've optimized lung protective ventilation, determine the PDAF ratio. And in patients with moderate to severe ARDS, a PDAF less than 150, I'm most concerned that spontaneous breaths and vent asynchrony may injure the lung. So these patients, I have strict lung protective mechanical ventilation, deep sedation and prone positioning, muscular blockade. Now, in patients with more mild to moderate ARDS and a PDAF ratio greater than 150, I still attempt to use lung protective mechanical ventilation. And in these patients, we have several studies that say that we don't need heavy sedation for mild to moderate ARDS to tolerate lung protective mechanical ventilation. I also try to minimize sedation, and when they start to improve and the underlying cause of ARDS improves, such as sepsis, I transition them to pressure support ventilation, but I keep an eye on the tidal volume. So despite having this approach, we have a lot of unanswered questions. So some of the questions that arise from this overarching question is, what's the benefit of neuromuscular blockade plus heavy sedation versus an attempt to minimize sedation? We don't know that answer. It's possible that the Pedal Network's ROSE trial that was recently stopped early, but we don't have the results of yet, might answer this, because in the ROSE trial, the control arm is a sedation approach that's decided by the clinician. There are a role of alternative sedatives, possibly DEX, in patients with ARDS. We also don't know long-term functional and psychiatric outcomes of neuromuscular blockade, proning, or ECMO. And then we don't know if we can limit sedation while proning or ECMO for ARDS. We obviously can't limit sedation in neuromuscular blockade, but we may be able to in other approaches to treating severe ARDS. Maybe there's a personalized approach where some forms of ARDS benefit from different strategies of management. So thanks again for listening and giving me this opportunity to present at this conference.
Dr. Devlin. He is a professor of pharmacy at Northeastern University and a member of scientific staff of the Division of Pulmonary Critical Care and Sleep Medicine at Tufts Medical Center in Boston. His federally funded research program is focused on the detection, prevention of delirium in the ICU.
I was the chair of the 2018 Pain Agitation, Delirium, Immobility, and Sleep Guidelines for FCCM. I just wanted to emphasize a few things about the guidelines from how they were formulated, some of the methods. I'll go through a couple of the recommendations, and then I'll try to talk to everybody a little bit about change using the ABCDEF bundle. So I'm on the third slide. And what's important to remember about these guidelines is they're very patient symptom related. Next slide, please. So when we're talking about it, we're really focused on recognizing, preventing, and treating pain, agitation, delirium, disrupted sleep, and obviously our patients often are immobile. So it's very much a symptom-related guideline. I think it's important to remember. And obviously these symptoms are prevalent in most of our critically ill adults. Next slide, please. We updated the 2013 PAD guidelines. I think what's important to remember is that we've added two new topics: rehabilitation, mobilization, and sleep disruption. These were touched on in 2013, but we convened two separate panels and developed and answered a number of important questions regarding this. We included ICU survivors right from the very beginning as collaborators and co-authors. We added experts from Europe and Australia to give it a little bit more of an international flavor. 70% of our questions are new from PAD 2013, so it's important to remember that this is not a replacement for PAD 2013, that these PAD 2018 guidelines should be used hand in hand with the PAD 2013 guidelines. One change from PAD 2013 is that we're focusing a lot more on, with our desirable critical outcomes, for our questions on post-ICU outcomes. So we're not focused quite as much on things like duration of mechanical ventilation or length of ICU stay. We're really looking at, cognitive and functional and mortality outcomes after people leave the ICU. The panel thought that these are important patient-centered outcomes to evaluate. And like every guideline, we actually had to stop our evidence searching on November 1st, 2015. So there's always going to be a gap with these large guidelines when you use the grade criteria. Next slide, please. This is an impossible slide to read, but what it is it lists all the topic areas under the 5 panels. So we make, 37 recommendations, 2 ungraded good practice statements, and 32 ungraded statements. Obviously, in 10 minutes today, it's impossible for me to go through all of these. So I urge you to, review the guidelines at your leisure. I think the other important thing, next slide, please, to note is only 2 of the recommendations are strong. Next slide, please. And it's important to realize to consider the differences between a strong versus a conditional recommendation. It used to be we would call conditional recommendations weak recommendations, and there's some key differences here. Basically, a strong recommendation applies to pretty much all critically ill adults that you might see in an ICU. But conditional recommendations usually apply to just a subset or most patients. The supporting evidence is much, much stronger with strong recommendations. The benefits clearly outweigh the burdens. However, with the conditional recommendation, the balance between benefits and burdens can actually be much closer. Generally, future research is probably not going to change a strong recommendation, but it could easily change a conditional recommendation, for example, a large, adequately powered randomized study. And generally, people can safely adapt a strong recommendation to daily practice in their ICU, whereas with a conditional recommendation, often there's a lot of bedside discussion that has to happen when you're applying the intervention with a conditional recommendation. And so clinicians have to do some more decision making. Next slide, please. This is another busy slide, but it's just to show the process we went through over the 5 years. We identified topics. These were voted on by panel members, and then there was a tremendous amount of influence on patients to identify the topic areas within the 5 domains or 5 panels that were felt to be most important to answer. We then identified obviously the PICO questions. We identified the critical outcomes. Again, patients had a lot of influence on these outcomes. And what's important to realize is we tried to do this separately from what we knew was published in the literature, and we didn't change the PICO questions as we identified new literature or whatever. That's kind of a no-no. We obviously use methodologists to evaluate the risk of bias and the quality of the literature. Most of our effort was actually spent on a number of conference calls with each panel going through the grade evidence and decision framework. Then we presented draft recommendations to a large group 2-day meeting, electronic voting, and then the final recommendation. So there's a number of important steps here, and we really followed the grade process rigorously. Next slide, please. If you want to see more information, we do have a separate methods paper. There's a number of innovative things we did with our guidelines in the context of other published critical care guidelines that you might be interested in. Again, as I mentioned, critical illness survivors were really actively involved on all phone calls. and it's amazing the perspectives that the critical care survivors provided. For example, I remember one call where we were looking at depth of sedation, which I'm going to be talking about in just a minute, and we had some top ICU sedation experts on the panel, and they were focusing on, well, we should always be using light sedation when it was safe for the patient. And our patient ICU survivor jumped in and said, there were times that I really wanted to not remember things and be more deeply sedated. So it was kind of interesting. That made the panel really think, hey, maybe there is situations where we should be asking patients their depth of sedation if possible. So there's actually a statement in our guidelines talking about that, patients might have some preferences about their depth of sedation. We use qualitative and quantitative approaches to developing all our descriptive questions. We used a really thorough three-step approach for generating final recommendations, and we really developed good consensus across the panel. This is where large practice guidelines can kind of fall apart. The other thing we did right from the get-go is we systemically identified and kept track of all evidence gaps that were identified. So you'll see in our manuscript, there's sections with evidence gaps all the way through the manuscript. Next slide, please. Lastly, we do have a separate interpretation and implementation paper. And when you go to Critical Care Medicine's website and look at the actual web-based one, not the PDF, but the web-based version of the full guideline manuscript, you can click on all these supplemental tables. And we have over, I think there's about 130 of them. And basically, it's sort of all of the detail behind the guidelines. If you want to see, for example, what were the prioritized scores for the topics that led to questions, you just click on, say, Supplemental Table 10. If you want to see the recommendation voting results, the evidence summary, all of the evidence and decision tables, which keeps track of everything that was discussed over the 4 years, and then the forest plots from an analysis. So there's a host of resources if you're interested, really drilling down to the detail behind the guidelines. Next slide. These are our authors and our panel members. Next slide. So I think I'd like to spend just a little time talking about pain and a little bit of time talking about sedation. I can't focus on most of the guidelines in the few minutes today, but I'd like to think, when we talk about pain, and pain is our first panel section in the guidelines, and when we talk about the ADF bundle, A is for assessment of pain. So pain is critical, and I'd like to sort of call it the wheel of pain misfortune, because if we're not recognizing pain properly, treating it, sometimes that leads to increased sedative use. It impairs rehab and mobilization, can increase delirium. This can actually, worsen critical illness, and it's sort of a cycle that goes around if we don't really think about pain assessment and treatment in our patients. Next slide. So we had an important PICO question about protocol-based pain assessment and management, and this is looking at using a protocol-based analgesia or a full analgesic sedation approach. Next slide. We differentiated in our guidelines analgesia-first sedation from analgesia-based sedation. So analgesia-first sedation is sort of the minimum that should be practiced, where we're treating pain before we reach for a sedative. Analgesia-based sedation is we're actually using the analgesic, usually an opioid, instead of a sedative to reach sedative goals. We're relying on the sedative properties of the opioid. So there's a little bit of differentiation here. Next slide. These are just the study characteristics, and without going through these studies in detail, there's so much heterogeneity in these 5 randomized studies that have been completed. All these studies have been completed in Europe. We actually couldn't even meta-analyze or synthesize the evidence between the 5 studies. And big differences between the interventions, the populations, and the outcomes that were evaluated. Next slide. There's key factors that led to the fact that we're only able to make a conditional recommendation rather than a strong recommendation. Only 3 of the 5 randomized studies have consistent results for critical outcomes. Most of the RCTs focus on specific ICU subgroups like medical patients. The behavioral pain scales like BPS or CPOP were not reliably used across these studies. Safety outcomes, particularly the side effects of opioids, weren't well reported. The choice of opioid varied. None of the studies were blinded, and in many cases, the control group wasn't as well differentiated from the intervention group as one might expect. So we did make a good practice statement. Obviously, the management of pain for adult ICU patients should be guided by routine pain assessment, and pain should be treated before sedative agent is considered. And then we make, a conditional recommendation about using a protocol-based, whether it's analgesia or anadrol sedation, in a stepwise approach for pain and sedation management. Next slide. This is just to touch on, we spent a lot of time focusing, and we have a number of PICO questions and recommendations focused on multimodal, non-opioid adjuvant analgesia therapy. At least in the United States, and I suspect in other places in the world, there's a large focus, particularly in surgical critical care patients, of reducing opioid use by using a multimodal analgesic approach. We make recommendations, and these are all conditional, to support the use of acetaminophen, whether it's oral, rectal, or IV, nefapam, which is not available in the United States but widely used in Europe, low-dose ketamine, and then neuropathic agents. We do not recommend IV lidocaine, mainly because of lack of evidence potential toxicity, and we don't advocate using an NSAID for more than 1 dose, again, based on lack of efficacy, and primarily based on the safety concerns with giving repeated IV NSAID doses to critically ill adults. We also do have a lot of non-pharmacologic recommendations surrounding pain, and we do make conditional recommendations regarding massage therapy as well as music therapy. So this is an algorithm that I pulled from the actual guidelines that clinicians might be able to use if they're looking to augment the use of opioids with the multimodal pain approach. But again, a lot of questions and evidence gaps, particularly in non-surgical critically ill adults. Next slide, please. I'd like to just touch on sedation. We did have an important PICO question looking at light versus deep sedation. We define light sedation as a RASS -2 to +1. And remember, in the 8 randomized studies we identified, we weren't looking at studies that were comparing, like the ABC study or daily interruption studies where patients have vacillated sort of wakefulness during the daily awakening and then deeper sedation at night. Those studies weren't included in our evidence profile. What we are looking at here with these 8 randomized studies and 3 observational studies was looking at patients that were consistently differentiated in the goal RASS that was maintained 24/7 across their ICU stay. Next slide. This just shows our RASS goal here. Next slide. Next slide. When we looked at the 3 randomized studies out of the 8 that looked at time to extubation, it was associated with the shorter time of extubation. And then in the 3 observational studies, we also found a shorter time to extubation with light sedation. Next slide. When we looked at the tracheostomy rate, it was less when patients were maintained with light sedation. Interesting enough, light sedation was not associated in the literature with reduced delirium, PTSD, or depression, and this was evaluated in 2 randomized controlled studies. Next slide. No difference in mortality. So we make a conditional suggestion to use light versus deep sedation in critically ill mechanically ventilated adults. So realize that, as Dr. Reilly presented just before me, there's obviously populations of patients where deeper sedation is a goal, particularly patients that have ALI or ARDS. The important evidence gaps here, there's no consensus on really the definition of light, moderate, and deep sedation. Changing sedation levels and their effect on clinical outcomes, really we're in our infancy in developing this relationship. The effect of light sedation on post-ICU patient-specific factors need to be evaluated. And then there's a dearth of information on the interactions between different sedatives like, Precedex versus dexmedetomidine, depth, and patient-specific factors. Next slide. We make it an important non-pharmacologic treatment recommendation using a multi-component approach, and there was multiple non-pharmacologic approaches we looked at. There's been various protocols, but the one that really came to light is the ABCDF bundle. I think most people are familiar with it, where we're assessing pain, completing both spontaneous awakening trials and spontaneous breathing trials, focusing on a daily basis on our choice of sedation and analgesia, and in fact, whether we need sedation in these patients, focusing on delirium assessment, prevention, and management, early mobility and exercise, and then family engagement and empowerment is an incredibly important part of all of this, and something that I know FCCM is really focusing on with their STRIVE initiative. What we found with the ABC bundle approach is less delirium, less mortality, and more coma-free delirium days when you look at the current published evidence, which was 2 key studies that were published a couple years ago. Next slide. So this is, our recommendation, and this is probably one of the most important recommendations in the guidelines, is really focusing on a multi-component non-pharmacologic intervention focused on reducing modifiable risk factors for delirium and improving sleep, mobility, and other attributes related to this. There's lots of evidence gaps in this area, but this is certainly, I think, sort of setting a practice standard for ICUs that want to make change in improving, pain, agitation, delirium, mobility, and sleep in their ICUs. Next slide. I'd just like to touch on an important paper that was published about 2 weeks ago in Critical Care Medicine. I was part of this effort, and it was basically was a quality improvement collaborative using the ADF bundle with approximately 80 adult hospitals, ICUs across the United States. And we evaluated our results in 15,000 adults. Next slide. And this is using the ADF bundle. We looked at a number of different patient-related, symptom-related, and system-related outcomes. Next slide. We looked at the ADF bundle performance in 2 ways: by complete performance, where the bundle was used in every patient every day, and then proportional performance, which probably mimics real-life practice more in many instances, where only some of the bundle elements that were eligible for that patient were actually performed. Next slide. We also then looked at the association between complete and proportional ADF bundle performance in 3 sets of outcomes, and we adjusted each of these outcomes with 18 potential covariates to really see what the true association was between bundle compliance and our various patient and ICU-specific outcomes. Next slide. I'm not going to go through this in detail, but virtually every one of these outcomes listed on the left here, the better the compliance was with bundle performance, the better the outcome was for the patient. It takes some interpretation to go through every one of these, and I won't in the interest of time. Interestingly, the only thing that we found that was increased with better bundle performance was more pain, and I would suggest that probably this is because clinicians were doing a better job of screening patients for pain, which of course is the A in the A to F bundle. Patients were more awake and they could self-report pain, and of course we were mobilizing patients a lot more, and mobilized patients might actually experience more pain than a patient lying in bed. So that's, I think, counts for maybe some of this a finding with respect to pain. Next slide. So I urge you to look at our interpretation and implementation paper. It goes through a lot of key quality improvement steps that you can take back to your ICU to implement the A to F bundle in the PAD 2018 practice guidelines. Next slide. One of the most important things, I think, is that we found in ICU liberation effort that I just presented the results on is changing the structure of the interprofessional team and how the ICU bedside interprofessional team communicates. And it's really focused around the patient rather than sort of the traditional hierarchical model of the intensivist sort of dictating orders to other clinicians. And I think this is the way. It's impossible for any one clinician to fully implement the A to F bundle. It's very much a team-based approach, working synchronously, but with some autonomy to make change. Next slide. And this is my final slide, and I think we just need to remember what we're really trying to do in the whole PADIS realm is take our critically adult patients and make as many interventions and changes as possible in the ICU so they will recover and regain their cognitive and functional ability to get back to the life they enjoyed before they became critically ill. Thank you very much.
Okay, well, thank you so much for all of our panelists and everything all the talks that were covered. And thank you for everyone for dealing with all of our technical issues throughout this. Because we're a little bit long on time, I'm just going to ask a question real fast, and then I'll ask one for Amy if she can't speak on this. So I guess my question that I have for Dr. Reilly is, I find myself making kind of the choice of sedation, deep sedation versus light sedation strategies are very difficult for me as well. I tend to be swayed a lot by the use of steroids and the use of ECMO, and sometimes with the use of steroids, I'll reach for ECMO earlier. Do you find that this changes you at all? Do you have any thoughts on this matter?
Sure. Thoughts on the use of ECMO in severe ARDS, or?
The use of ECMO, when I use ECMO earlier when I'm using high-dose steroids because I'm able to liberalize my sedation more than when I use neuromuscular blockade and proning.
Sure. So my practice tends to be with ECMO is I tend to reach for it when the other processes have failed. So I go for neuromuscular blockade and proning first in severe ARDS. And when we just have life-threatening hypoxia, or I'm not able to get the plateau pressures to be in a safe range to prevent ventilator-induced lung injury, then we'll pull for ECMO. And absolutely ECMO earlier rather than waiting long into ARDS seems to be where the benefit is.
Thank you. And now just a question that Dr. Arrington had. She says that she finds that polypharmacy of sedation and opioids, et cetera, is usually heavily present in delirious patients and can be difficult to conquer if the goal is to dramatically reduce benzos. But this can be very difficult in some patient populations, like children. Are there any strategies to overcome? Dr. Devlin, do you have any thoughts on this?
Yeah, I think that's a great question. Polypharmacy definitely is a big issue in the ICU. I'm a pharmacist by training. I think the most important thing is thinking about the symptoms that we're trying to treat in a patient with delirium. We really want to make sure that their agitation isn't related to pain. If patients remain agitated and they're not in pain, I think the most important thing is to get the restraints up and sitting up in bed if possible and moving, or at least standing, So I think mobility plays a big role in decreasing the medications that we use for agitation in delirious patients. I think the other important thing is and the ADS bundle really, the C in this is critical, is that there's a daily, or sometimes more often than daily, reevaluation of the medications that patients are getting. And I think we need to move our mindset that where we start a patient on a sedative regimen or a regimen to keep them comfortable, that we're not just adding to that regimen, that we're making changes each day, and the elimination of drugs, I think, is most important, and not just keep adding on medications, and particularly when patients leave the ICU, making sure that we really have a clear plan that we're not sending them out of the ICU on medications that probably aren't needed anymore, and can certainly have longer-term safety considerations, particularly things like antipsychotics.
Thank you so much, and I appreciate all of our panelists. And on behalf of Dr. Arrington and myself, I'd like to thank everyone for this opportunity.
Hello, I am Janice Zimmerman, President of the World Federation of Societies of Intensive and Critical Care Medicine. I would like to offer a warm welcome to everyone who is participating today in the World Day of the Critical Lung. I would also like to offer my thanks to the many speakers who are sharing their time and expertise today. My warmest and sincerest gratitude and congratulations to the Pan American Federation of Societies of Intensive and Critical Care Medicine for organizing and providing free education about these important issues of the lung. Hopefully, the knowledge will result in better outcomes and care for patients throughout the world. Thank you.
The European Respiratory Society, I'd like to wish you every success with your meeting. Respiratory disease is something that affects millions of people worldwide, and taking care of these patients, especially in circumstances of emergency and critical care, is extremely important. There are many patients, there's a lot of suffering, we should be able to prevent it and alleviate it. The European Society is the largest respiratory society. We're European-based, but we have members in 162 countries, over 32,000 members, and we all try to do our best for our patients. So We promote science, we promote education for our members, but also education and information for our patients and advocacy. So we work with policymakers to make sure that everything, easy access to care, early diagnosis, and best care is available for our patients. With this in mind, I'd like to wish you every success to your meeting. Everything we do in respiratory medicine is important and it has an effect on patients. And I would also like to invite you to our meeting in Paris this coming September. Every success to your meeting.
HM Hospitales was born in 1990 and was created by Dr. Juan Abarca Campal. Along with Dr. Carmen Pidon Damargo, they directed and led a team of doctors and managed to initiate a new model of private medicine in Spain. Assistance quality, professional qualification, researching, teaching, and technology are the pillars that sustain this project that takes shape with the renovation and reawakening of former Hospital San Pedro, currently known as Hospital HM Madrid. Ever since,